Hello, good evening, and welcome to our today's CME program entitled Clinical Tipping Points in Portal Hypertension, a virtual broadcast. We're thrilled to be having a conversation this evening about some important clinical principles in the management of patients with portal hypertension in the context of liver cirrhosis. I'm joined by my colleagues, Patrick Horne, nurse practitioner at the University of Florida, and assistant clinical manager and director of research, and my colleague, Dr. Robert Wong, who is Associate Professor of Medicine at the Stanford University School of Medicine. My name is Joseph Lim, a hepatologist at Yale University, where I serve as Director of Clinical Hepatology. Today's program is jointly provided by Medical Education Resources, the Chronic Liver Disease Foundation, in collaboration with Gastroenterology and Hepatology Advanced Practice Providers, also known as GAP. And this is supported by an independent educational grant from Gore and Associates. The goal of today's program is really to meet the educational needs of GI and hepatology clinicians in the management of patients with portal hypertension. And in the next hour, we're trying to go through some basic principles about what is a portal hypertension, how do we define and diagnose a portal hypertension that's viewed as clinically significant, how do we manage portal hypertension, both regards to initial preventive strategies to reduce the risk of complications, as well as a brief review of the current principles in the management of complications of portal hypertension. So these are my colleagues here who are joining us together in the discussion this evening. And so I will be going in sequence in terms of our presentations. And to the degree to which is appropriate, I'll ask my colleagues to introduce themselves at the beginning of their appropriate section. These are our objectives. First is to explain how increased intrahepatic resistance and splanchnitic vasodilation contributes to increased portal pressure, to justify the selection of specific interventions for patients with complications of portal hypertension, such as hydrothorax, ascites, and varices. And number three, to critically evaluate the efficacy and optimal timing of a multidisciplinary approach on management within the portal hypertension care pathway. This program is accredited for continuing education for 1.0 AMA PRA Category 1 credits. And in our discussion, you will have instructions that'll be sent to you by email with further details about how to claim your credit upon successful completion of this program. On this slide, we present the disclosures for myself and my two colleagues as faculty for today's program. Furthermore, the organizers of today's program, including Medical Education Resources and the Chronic Liver Disease Foundation, report no relevant financial disclosures. These are some disclaimers here about the content being presented today. This is not intended to be a guideline for patient management, but has helped to inform evidence-based approaches to the management of patients. This is instruction about how to claim credit. I won't read through this in detail, but for those who have not already done so, there are instructions to complete a pre-test prior to the program, and upon completion of the content, you'll be given instructions for completing a post-test, program evaluation, and how to go ahead and claim your credit and get the certificate. On the right, there is a QR code for those of you who want to click on that at this time. So they'll take you to a site where you can complete this process. So let's go ahead and get started. And so our first topic is pathophysiology and diagnostic approach to CSPH, also known as clinically significant portal hypertension. So the first question, what is this entity? And I think most of you on this call will likely be quite familiar with this concept. But the general principle behind it is that in patients with chronic liver disease of any form, whether it's viral hepatitis, mesothelioma MASH, ALD, autoimmune liver diseases, etc., the principle of most chronic conditions is that of chronic liver inflammation, which leads to progressive fibrosis over time, typically over the course of many years, to the point where there's fixed scar, and this cumulative scar at the level of cirrhosis can reach a critical juncture where there is a change in blood flow or vascular blood flow that can lead to resistance to that flow, also known as portal hypertension. And this is of great clinical importance because it provides the first distinction in terms of clinical risk. We recognize that among patients with compensated cirrhosis, Child-Pugh A, there is early Child-Pugh A compensated cirrhosis where there is no evidence of CSPH, and a later group of patients who do have CSPH for whom there's a much higher risk of clinical complications in terms of progression to decompensation and other liver events. And furthermore, it is often believed that once you have reached this level of CSPH, you've reached a point of no return in terms of histologic reversibility of fibrosis. So, what are the definitions of the portal pressure that meets the CSPH threshold? And this is currently defined as a hepatic venous pressure gradient of 10 millimeters of mercury. But clinically, it is not practical to directly measure this with HVPG measurements through interventional radiology or hepatic hemodynamic laboratory, but is more commonly measured either by the presence of portal hypertension on endoscopy with esophageal gastric varices, or alternatively is with non-invasive testing with one or more non-invasive tests such as serum fibrosis assays or liver stiffness measurement that reach specific thresholds that suggest the presence of CSPH. We're going to discuss this a little bit more detail in a moment. But just to review some of the pathophysiology, although this is familiar to many of you, remember the concept of chronic inflammation, progressive fibrosis, reaching a critical threshold of portal pressure where there's increased resistance to portal blood flow that is paired with increased portal venous inflow that results in splanchnic vasodilatation and a hyperdynamic circulation in patients with cirrhosis. This ultimately will lead to a decrease in effective arterial blood volume, which turns on what is known as RAS, also known as the renal angiotensin aldosterone system. This ultimately leads to the clinical complications of portal hypertension, such as ascites, hepatic hydrothorax, hyponatremia, and hepatorenal syndrome. And so as we progress regards to the degree of portal pressure with clinically significant hypertension along the spectrum of pressure, that the risk for these complications correspondingly increases. So in this slide, what we hope to do is to take a deeper look at some of the non-invasive tools and thresholds that might be useful in our clinical practice to identify patients with clinically significant portal hypertension. And so the three tools I'll first highlight are things that are generally available to most of us, including platelet count, liver stiffness measurement, and or HVPG, which of course is less commonly used in the clinic. The platelet count generally is going to be between 150 to 450 per in terms of the blood test result. And the rule of thumb historically in our training was that if you had a patient with chronic liver disease and a platelet count under 150,000, that this was most suggestive of someone with advanced fibrosis at minimum and likely cirrhosis in many of these individuals. In fact, once a platelet count goes below 100,000, it is often presumed to have cirrhosis until proven otherwise. And therefore, as the platelet count goes from more than 150 to 110 to 150, you're transitioning from someone who's at low risk to intermediate risk for CSPH. And once you get to below 110,000, the likelihood of CSPH and decompensation significantly increases. This also corresponds with varying levels of liver stiffness measurement, less than 10 kilopascals, low risk, 10 to 20 kilopascals, intermediate risk, and more than 20 kilopascals of pressure, high risk for CSPH and decompensation. Now, the complications we've already begun to highlight here, including ascites and its associated complications such as hydrothorax, hyponatremia, and hepatorenal syndrome, but also variceal hemorrhage, typically esophageal or gastric, as well as hepatic encephalopathy. Among patients with compensated cirrhosis who have CSPH, the risk of decompensation is approximately 10% at 2 years and over 30% at 5 years, with substantially lower risk among those with compensated cirrhosis without CSPH. Furthermore, the median survival is over 12 years in those with compensated cirrhosis at the beginning, but drops to less than 1.5 years at the time of index hepatic decompensation event. This is just another way of trying to categorize patients with regards to severity of CSPH based on their HVPG measurement. And the idea here is that generally what's normal HVPG is less than 6. Once you hit 6 to 10 millimeters of mercury, that's portal hypertension, but it's the threshold of 10 millimeters of mercury that's viewed as clinically significant, which is associated with increased risk of clinical complications. And more than 12 is usually the threshold where we believe someone is at risk for variceal hemorrhage. In other words, 10 millimeters mercury to develop varices, more than 12 for them to bleed. Once you get to more than 16, that's considered very severe. And more than 20, these patients are considered to be very high-risk patients for decompensation events. So we're going to walk through in the next slide, some of the nomenclature and some of the grades of risk for what we call CACLD, which is also known as compensated advanced chronic liver disease, which generally groups CH3 fibrosis and cirrhosis patients in the same continuum, and then CSPH, as we've highlighted. And so up top, we talk about liver stiffness measurement along the gradation. And again, once you're below 10, the risk is low. 10 to 15, obviously, they may possibly have CACLD, but typically not likely to have CSPH. 15 to 20, they are likely to have CACLD and probable CSPH. And once you get to 20, this is highly probable to have CSPH. And for those who are familiar with the AASLD guidelines, the threshold beyond which we strongly rule in CSPH is a threshold LSM greater than 20 kilopascal pressure and a platelet count less than 150. Now, there are many other alternatives to liver stiffness measurement that may be considered, including traditional endoscopy for those for whom liver stiffness measurement is not available. There's often questions that are raised to all their alternatives to traditional VCTE-based elastography versus shared-wave elastography and serum markers such as ELF score. And down below, you'll see some cutoffs that are commonly used to rule in CSPH using these alternative markers. So let's transition to how we can optimize intervention for patients with CSPH with the aim of trying to reduce the risk of decompensation events. So here are some key principles. So first, in patients who are compensated today, your hope is that you can take actions to address the primary cause of liver disease. If it's alcohol, to help to achieve a long-term sobriety. If it's hepatitis C, treat with DA, Hep B, control antivirals, MASH to control the MASH, et cetera, et cetera. But number two is trying to take steps to risk stratify based on the presence or absence of CSPH with NITs and or endoscopy. And if they have CSPH, to take interventions to reduce or prevent the development of hepatic decompensation. The AASLD guidelines do signal one particular intervention as guideline recommended, first line recommendation, and that's for non-selective beta blockers, preferentially carvedilol at a total dose of 12.5 milligrams daily in divided doses. So we're talking about 6.25 milligrams BID, and this should be considered for all patients with CACLD, that's F3 or F4, with CSPH to reduce the risk of decompensation. Now, non-selective beta blockers should not be administered to patients who have contraindications. We'll walk through some of this in greater detail, but this includes those with severe asthma, advanced heart block, and arrhythmias. And in these patients, you should really carefully consider the benefits and risks of administration. In addition, there are patients for whom they have CSLD, CSPH, and are candidates for and non-selective beta blockers. And in those patients who do have contraindications, traditional endoscopy may be warranted both to identify CSPH, characterize it, in some case, preventive or primary prophylaxis with band ligation. All right, so here's a schematic of some experts' perspectives on management for compensated cirrhosis patients. On the left, these are patients without CSPH. And for these patients, of course, we don't use beta blockers, but we prioritize lifestyle modification, treating the underlying liver disease. In the middle group, these are patients with proven or likely CSPH, but without known varices. And in these individuals, non-selective beta blockers are strongly indicated. And again, the target dose of carvedilol is 12.5 milligrams daily. And as a general rule, I like to start low and go slow with 3.125 BID, that's total dose of 6.25, and titrating up as tolerated. And for those who have contraindications or use initiated beta blocker but is not well tolerated, in those individuals, traditional endoscopy is warranted. And if they meet eligibility for prophylaxis with band ligation based on the presence of medium or large varices, that should be pursued. And then finally, on the right, those with proven or likely CSPH with varices, generally it's the same principle, is that beta blockers are first line, but band ligation is viewed as a backup option for those who have contraindications or are intolerant of beta blockers. So on the right here, I do want to call out some of these contraindications because I'd say that many of the contraindications that we have historically believed to be a big no-no may no longer be considered absolute contraindications, but potentially relative contraindications. So the absolute ones are probably severe asthma. I would still take great caution in considering beta blockers in this population. Those are second or third degree AV block, particularly in the absence of implanted pacemaker. Those with sick sinus syndrome and extreme bradycardia with baseline or basal heart rate under 50 beats per minute. But the rest are really relative contraindications where you want to make an individualized choice with your patient with consideration of benefit and risk. And these include things like psoriasis, peripheral artery disease, COPD, pulmonary artery hypertension, insulin-dependent diabetes mellitus, and Raynaud's syndrome. In the next two slides, I'm going to briefly touch on, in the interest of time, a couple studies that I think help to underscore the evidence base for non-selective beta blockers. This includes the landmark paper called the Predesti randomized placebo-controlled trial, in which 200 patients with compensated cirrhosis and CSPH, but without large varices, they had to be none or small, were randomized to either propranolol or placebo, basically a beta blocker or placebo. And this includes both responders to propranolol and non-responders to propranolol. And what they demonstrated was that there was a significant decreased risk of the primary event of incident cirrhosis decompensation, including ascites, bleeding varices, or overt hepatic encephalopathy, or liver-related death. And the Kaplan-Meier curve you see to the right, there's a significant difference or delta between those on beta blocker versus those on placebo, and with a hazard ratio of 0.22, which did meet statistical significance. And then in the final data slide here, I'll highlight that there's a competing risk meta-analysis that was performed specifically evaluating carvedilol and its impact on decompensation and mortality, up above decompensation and below on mortality. And what we see here is that there is a pretty clear signal in pooled analysis for decreased risks of these liver events. So at this time, I'd like to transition to our next speaker, my colleague, Dr. Robert Wong from Stanford University.
Thanks, Dr. Lim. So now we're going to move on to think about how we apply those principles that we just learned about clinically significant portal hypertension and apply them to some specific examples of cirrhosis complications. So we're going to talk about variceal bleeding and then subsequently talk about ascites. This figure here just sort of summarizes big picture approach, how we manage acute variceal bleeding. We're going to go into some of these steps in more detail in the subsequent slides, but the key points here are: one, when a cirrhosis patient presents with acute variceal bleeding, there are some foundational treatment approaches that apply regardless of the location. And these would include resuscitation, vasoactive agents, antibiotics, and early investigation with endoscopy and hemostasis. The other key point here, which is illustrated in the little figure to the top right, is location. Location of the varices and the type of varices can help guide the subsequent approach to continued management of bleeding and prevention of recurrent bleeding. Here are some key points just to summarize the management of acute variceal bleeding. As I mentioned, key first steps are resuscitation, vasoactive agents, antibiotics, and then the application of endoscopy. An early endoscopy is appropriate, and if possible, endoscopic variceal ligation for hemostasis should be pursued. If portal hypertension is confirmed, vasoactive agents typically should be continued for 2 to 5 days post-endoscopy. In patients with Child-Pugh B7 or those with C, preemptive tips can be considered. And this is some of the data that we're going to talk about with some specific studies in some of the subsequent slides. What about non-selective beta blockers? In patients who present with acute variceal hemorrhage who don't undergo TIPS, non-selective beta blockers should be started for prevention of rebleeding, secondary prophylaxis, because these are patients who have bled and you're trying to prevent recurrent bleeding. We're going to talk a little bit more about TIPS in some of the subsequent slides, but in situations or centers where there are expertise, esophageal stenting or balloon tamponade can be considered as a bridge to TIPS for those who have uncontrolled hemorrhage despite endoscopy. This is the first study I wanted to review. This is a recent study published in Lancet. It was a randomized controlled trial of patients with Child-Pugh B or C cirrhosis. These are individuals who presented with acute variceal bleeding and achieved hemostasis with treatment with vasoactive drug plus endoscopic therapy. Then they assigned 2 to 1 patients to undergo early or preemptive TIPS and then standard of care therapy. There are a total of 132 patients, 86 assigned to the early TIPS group and 46 assigned to the standard of care control group. The primary outcome was transplant-free survival. When you look at the figure on the right, the red line represents those that underwent early TIPS, and the blue line represents those that proceeded with standard of care. You can see in box A that represents transplant-free survival, box B, recurrent uncontrolled bleeding, or figure C, worsening ascites, and then D, encephalopathy. And the key point here is that those populations that underwent early TIPS had significantly better outcomes with respect to survival, recurrent uncontrolled bleeding, as well as worsening ascites. And there was no difference in hepatic encephalopathy, at least in this specific study. What about salvage? Typically, salvage TIPS is what most of us are more familiar with and utilize TIPS for. Salvage TIPS can control bleeding, but carries high mortality. And that's probably because of selection bias. We're really saving this as sort of a last-ditch effort for those with uncontrolled bleeding that's refractory to other hemostasis attempts. But is there a way to select patients who do better? So these are some data from a recent systematic review and meta-analyses of 23 studies inclusive of 1,430 patients. And they found that 1/3 of patients who were treated with salvage TIPS died within 6 weeks. But the important thing here is they identified certain pre-TIPS markers, specifically lactates and the MELD score. And depending on the lactate and MELD score, if you had high thresholds, 6-week mortality was 90%. But if you selected patients that had a low lactate and a low MELD, it sort of flipped the other way around. Only 15% of these people actually died. So patient selection here is key. And because of that, the guidelines do recommend or do suggest that salvage TIPS may be futile in certain populations, including those with Child-Pugh score greater than 13, high lactate or MELD, as suggested by the study, and of course, those that have other contraindications such as ongoing active infection, renal failure, or continued need for vasopressor therapy. Let's move on to gastric varices. Gastric variceal approach to gastric variceal bleeding is similar to esophageal varices. Again, the initial management is the same. You want vasoactive therapy, resuscitation, antibiotics, and early EGD. But depending on the location, the approach can be different. And that's why sort of the second line approach to this is thinking about where the varices are located, what type of varices, and hence the importance of early EGD to kind of help distinguish between those. When we think about bleeding gastric varices, especially the GOV2 and IGV1, and you can see what those mean based on the figure on the top right, different types of therapies, including cyanoacrylate, TIPS, or retrograde transvenous variceal embolization or obliteration, VRTO, can be considered as first-line therapies. We're going to talk about some of the comparative studies in the subsequent slides. Patients treated with cyanoacrylate glue, though, should be additionally treated with non-selective beta blockers to prevent rebleeding. And these individuals should undergo repeat EGD at 2 to 4 weeks until obliteration. Patients who have bleeding gastric varices due to splenic vein thrombosis should be evaluated for splenectomy, splenic vein stenting, or splenic artery embolization. So really important to understand not just location, but the contributing causes and risk factors associated with the bleeding presentation. So let's look at some of the comparative studies. So this is the first study I wanted to review, comparing TIPS versus cyanoacrylates. It's open label randomized controlled trial of 100 patients who presented with acute fundal gastric variceal bleeding. These are people that underwent endoscopic glue and vasoactive therapy and achieved hemostasis. They were then assigned to TIPS or continued cyanoacrylate glue, meaning if they rebled, they would repeat gluing, etc. 1-year incidence of hepatic encephalopathy was similar in both groups. But the key here is that, which is illustrated in the slide on the right, or the figure on the right, those that underwent TIPS had significantly better survival. And you can see the red line represents those that were randomized to TIPS, and the blue line were those that underwent repeated cyanoacrylate gluing. So there's a lot of smaller studies, and this is a very nice recent paper published just this year that tried to combine all of these studies that evaluated these different approaches for bleeding from varices into a meta-analysis. They did both an aggregated data meta-analysis as well as individual patient data meta-analyses, and they compared endoscopic cyanoacrylate glue injection, BRTO, and TIPS. And you can see from the two figures on the right, compared to cyanoacrylate alone, both BRTO and TIPS were associated with lower risk of rebleeding. However, they also noted that those that underwent BRTO had higher risk of new onset or worsening ascites, and then those that underwent TIPS had higher risk of hepatic encephalopathy. Furthermore, they found that the reduction in bleeding risk was most pronounced among those with Child-Pugh B cirrhosis. What about BRTO versus TIPS? So that meta-analysis showed that BRTO and TIPS were both better than cyanoacrylate, but what if you compare these two options together? There haven't been that many studies, but not too old meta-analyses included 5 observational studies that evaluated BRTO versus TIPS for treatment of gastric varices. And the study suggested that BRTO approach may be superior for rebleeding with less hepatic encephalopathy, but at the cost of worsening ascites. And you can see some of the specific numbers that they quoted here in the study rebleeding, higher risk of rebleeding in TIPS, higher risk of encephalopathy. But when you look at ascites, much higher worsening of ascites seen in those that underwent BRTO. And then at least in this smaller meta-analyses comparing the two, there appeared to be lower mortality associated with the BRTO approach. So in general, these are sort of high-level kind of factors that would maybe tip you towards BRTO or TIPS. BRTO is preferred in patients with hepatic encephalopathy, high MELD sodium, cardiac contraindications, and something called the Freiberg index. The Freiberg index is used to kind of predict the likely or the complications associated with TIPS. It's a scoring system that includes 4 different simple variables. It included, I think it was age, bilirubin, albumin, and creatinine. That helps predict who would likely benefit more from BRTO versus TIPS. And then TIPS would be preferred in those with lower MELD score, those who had significant ascites, patients with portal vein thrombosis, and absence of hepatic encephalopathy. What about follow-up after a patient undergoes these procedures? Post-TIPS, it's important that these patients undergo Doppler evaluation to ensure patency and whether TIPS is functioning correctly. With respect to BRTO, post-BRTO imaging, including either CT or endoscopic ultrasound, should be performed to evaluate complete obliteration of the varices. Follow-up endoscopy should also be performed to look for any development or progression of varices after BRTO. And if there aren't any, then you would just continue the standard recommended surveillance protocol for varices. This is, so tips for gastric varices. So depending on location, the approach is slightly different. As we mentioned, for lesser curvature gastric varices, tips should be favored for bleeding refractory to band ligation or for recurrent bleeding. And then for GLV2 and IGV1 varices, tips can be used and is most efficacious when combined with direct embolization or endovascular sclerosis. Tips alone is not in fact or less effective for cardiovascular varices because these bleed at lower portal pressures. And portal pressure reduction with tips may still allow up to 50% to rebleed. Tips for gastric and ectopic varices should be accompanied by simultaneous collateral obliteration or embolization. And then finally, tips combined with direct obliteration is indicated when portal hypertensive complications are too severe for BRTO to be feasible. Now moving on to ascites. All patients with nuanced ascites should undergo diagnostic TAP to rule out SPP. And then management includes dietary sodium restriction, diuretics, and then of course education to ensure dietary modification is appropriate. Patients that undergo large volume para should be repleted with albumin to prevent complications associated with it, such as hypotension, electrolyte abnormalities. And then refractory ascites or hydrothorax should be managed with therapeutic para and or thoracentesis, and the frequency guided by recurrence. When thinking about how to select or apply TIPS intervention in those with ascites, the field is certainly evolving, and we're going to talk about some of those studies in the subsequent slides. When we think about management of ascites, as I mentioned, this is a figure that shows kind of the stepwise approach and the important factors to consider. When you start someone on diuretics, you don't start and stop. You have to make sure you monitor for adequate response and continue adjusting the diuretics to ensure a balance of ensuring adequate diuresis, but also monitoring whether there are electrolyte abnormalities, bump in the creatinine, etc. And it has to be done in a very careful stepwise fashion. Patients who develop refractory ascites may then be eligible for TIPS, but they should be also evaluated for large volume para with albumin repletion as well. When thinking about refractory ascites, we have to make sure we're defining things appropriately. Patients should be treated with appropriate diuretic therapy for at least a week associated with salt restriction. If someone's eating fast food cheeseburger every day, you can't really call that refractory ascites because you have to make sure you balance and optimize this approach before calling it a failure. Lack of response, both by measuring weight as well as urinary sodium output, and then early ascites recurrence are some of the key features that define refractory ascites. And then diuretic complications are also important. These are things we have to monitor very closely, especially as we titrate diuretics. And these development of these um, complications or intolerances can prompt you to then proceed with large volume para and TIPS evaluation. In terms of refractory ascites, and these are pulled from the European EASL clinical practice guidelines, large volume para is safe and effective, but must be repleted with albumin to prevent some of the complications that we mentioned. Diuretics should be discontinued in those with refractory ascites who do not excrete adequate sodium because it's not helpful and then would continue to contribute to complications. Beta blockers are a little bit controversial in refractory ascites, and caution should be used in certain scenarios. So really, it depends on the patient, risk factors, etc., when thinking about whether to use beta blockers, continued beta blockers, in those with refractory ascites. And then indication for TIPS. TIPS is indicated for refractory or recurrent ascites when large volume para is ineffective. And it's been shown in some of the studies we will show to be associated with improved survival, improved control of ascites. And after TIPS insertion, it's still important to continue diuretics and salt restriction and close clinical follow-up and monitoring to ensure that the stent is functioning correctly. And then this is one study to really summarize the data thus far for TIPS for refractory, preemptive TIPS, or prevention of bleeding. This is a large individual patient analysis that included 12 controlled studies, almost 4,000 patients, and they compared TIPS to standard of care. Propensity score matching was applied, and the outcomes were incidence of further decompensation and overall survival. And you can see summarized on the figure on the right that application of TIPS was associated with decreased risk of decompensation and improved survival in these populations. And then finally, just a slide on hepatic hydrothorax. That's something that some of you may encounter. TIPS is recommended as second-line therapy for refractory or recurrent hepatic hydrothorax that does not respond to sodium restriction and diuretics. It can be used as definitive treatment or as a bridge to transplant in those that are eligible. And TIPS can achieve portal decompression, and that's sort of the underlying principle that we learned in some of the earlier slides. Effectiveness of TIPS placement in controlling hydrothorax was complete in 56% and partial 18% in a recent study. The pre-TIPS MELD is the strongest predictor of survival. We saw this in TIPS for ascites as well as in varices, and MELD less than 15 was associated with much better outcomes. However, it's important to remember that liver transplant remains the only curative therapy in this population. With that, I'm going to turn it over to Patrick Horne to take on the next session.
All right, thank you very much, Dr. Wong. Now I'm going to take you through the latest evidence and timing around candidate selection for TIPS, to basically expand upon some of the topics that both Dr. Lim and Dr. Wong spoke on. So practical considerations for TIPS. So just to reiterate, TIPS is an endovascular shunt procedure. It is usually placed under radiographic guidance, and it's essentially connecting the portal system to the systemic circulation. And the goal, of course, again, is to decrease the portal venous pressure gradient, as you've heard about several times this evening. The portal flow is diverted, but by doing this, you're going to increase anywhere between 50 to 100% of the right atrial pressure, the cardiac preload, as well as the central blood volume, and up to 15% of the cardiac output. The stents being used are covered stents, and they're extending into the hepatic vein and IVC junction. Now, it's important because of that to have pre-TIPS cross-sectional imaging to ensure that the anatomy is appropriate and applicable and that the TIPS can be placed in the appropriate place. As Dr. Wong alluded to a few slides ago, smaller stents, specifically the 8 mm stent, seems to be the most sufficient stent to prevent not only variceal rebleeding, but also to potentially decrease the risk of hepatic encephalopathy in these patients. So again, using the 8 mm stent in comparison to, say, larger stents such as the 10 mm may actually lead to a survival advantage. Prior to TIPS, one can consider prophylactic rifaximin given 2 weeks before, and that has been shown to reduce post-TIPS overt hepatic encephalopathy, or OHE. Lactulose, which I'm sure we are all familiar with, can be used to treat and prevent HE recurrence, as in patients without TIPS, despite lack of specific studies. And then rifaximin, again, may be added in case of failure to lactulose or as a replacement for lactulose in cases of intolerance. So some indications for TIPS, you've heard a little bit about this already. Uncontrolled variceal bleeding, as well as high-risk acute variceal bleeding, can also be considered as a secondary prophylaxis for recurrent hemorrhage despite optimized medical therapy through either endoscopic banding or beta blockers. Refractory ascites, as Dr. Wong just went through, that require large volume paracentesis, hepatic hydrothorax, or in cases of hyponatremia where the use of diuretics is limited. This is a busy chart, but just want to take you through some of the highlights. Basically, just looking at the areas in which to evaluate before considering someone for or putting some or in doing a TIPS on someone. So the first is obviously a consultation with a specialist, whether that be a hepatologist, gastroenterologist, obviously most likely an interventional radiologist who is most likely going to be the one placing the stent. Evaluation of the patient, not only clinically and physically, but also using laboratory testing, labs to assess MELD scores you heard about, also assessing Chiao-Pugh, and then again, that cross-sectional imaging to evaluate the anatomy to make sure that a TIPS is feasible in that particular patient. And then also looking for other underlying causes of cirrhosis or other underlying comorbidities that could preclude the patient, such as cardiometabolic issues, renal issues, hematologic, and then obviously the presence of hepatic encephalopathy at baseline and to what severity that may be. So factors that may increase post-TIPS complications: patients who are of older age, so greater than 65. As you heard, higher MELD or higher Chiao-Pugh score, specifically Chiao-Pugh-C, or a MELD greater than or equal to 18. And you can see that patients who are unstable at time of hospital admission and have a high MELD at the same time have a very high 6-week mortality rate of almost 78%. Again, cardiopulmonary insufficiency, sarcopenia, or that prior hepatic encephalopathy at baseline. Renal dysfunction, including elevated creatinine or hepatorenal syndrome type 2. Again, hyponatremia, elevated bilirubin, elevated ammonia levels, and then comorbidities such as diabetes. So in terms of complications from TIPS, rarely do we see complications from the procedure itself. However, you can see things listed here: intraperitoneal bleeding, arterial injury, liver infarct, hemophilia, perhaps an immediate TIPS thrombus, and sepsis. Where we typically see complications from TIPS is usually related to the shunt itself after it's placed. Hepatic encephalopathy being the largest one, up to 50%. TIPS can thrombose and do require revisions at times. Cardiac decompensation, new onset pulmonary hypertension, and always the possibility of a recurrent variceal bleed or recurrent ascites if the TIPS is not functioning properly or not placed correctly. So this is a randomized control trial, just sort of building on that earlier conversation we had about the use of early TIPS, specifically in patients with variceal bleeding. So this was a randomized control trial of 63 patients with cirrhosis who all had acute variceal bleeding. They were treated appropriately with vasoactive drugs plus endoscopic therapy. And then, as you heard earlier, very similarly, randomized to either TIPS within 72 hours versus continuation of sort of standard of care of that vasoactive therapy followed by non-selective beta blockers and surveillance with EGD. TIPS was used in that second group as a rescue if needed. Excuse me. And what they looked at was the 1-year probability of no rebleeding. And you can see that the early TIPS group was 97% compared to 50%. And also, when you look at survival, the early TIPS group had a 1-year survival of 86%, and that was compared to only 61% in the standard of care group. Along those same lines, looking at preemptive TIPS, again, in acute variceal bleeding, this was a meta-analysis. And overall, what they showed was early TIPS, preemptive TIPS, improved 1-year survival, had a higher prevention of rebleeding and or ascites. And in this particular meta-analysis, they did not see an increased risk of hepatic encephalopathy in people who received preemptive TIPS. So again, preemptive TIPS, these are the guidelines and recommendations from both the AASLD as well as the Baveno 7 group. Very similar, basically saying that patients with acute variceal hemorrhage, a preemptive or early TIPS, within 72 hours, but ideally less than 24 hours after an initial upper endoscopy should be considered when the patients meet the following criteria. And the criteria is essentially the same for both the AASLD as well as Baveno 7. And that includes, as you heard earlier, Child-Pugh Class C or Child-Pugh Class B with active bleeding at initial endoscopy. The only real difference between them is the Baveno 7 group also adds in that high HVPG measurement of greater than 20 millimeters per mercury as another consideration at the time of the hemorrhage. So what about early TIPS for ascites? Just again, to expand on what we heard earlier, early TIPS insertion at the stage of recurrent ascites rather than waiting for refractory, as Dr. Wong sort of defined earlier, does show promising survival. So a 1-year transplant-free survival of 93% in those who had recurrent ascites versus 53% in those who had 93% survival versus 53% in those who received early TIPS in recurrent ascites versus those who received standard medical therapy. Randomized control trial, small study of 62 patients. This was done in France between the years of 2005 and 2012 across 4 tertiary centers. Covered TIPS versus large volume paracentesis with albumin, as well as maintaining a low sodium diet. And the primary endpoint was survival without liver transplant up to 1 year. And you can see on the graph to the right that the purplish blue line at the top is the TIPS group compared to the green line, which was the large volume paracentesis and albumin group. And you can see there was a clear difference in the transplant-free survival within the TIPS group. Again, this was a retrospective multi-center study looking at the role of early TIPS, again, in the management of both recurrent and refractory ascites. You can see there was large numbers. Groups were divided into large ascites, preceding recurrent or refractory ascites, who received TIPS versus a group that with recurrent and refractory ascites who received a TIPS, and then a smaller group who had large ascites that also preceded recurrent or refractory ascites and received medication and large volume paracentesis. And what they found was there was a significantly better control of ascites, as well as a lower liver-related death and lower rates of overt hepatic encephalopathy in that early TIPS group. This is an ongoing study, the eTIPS trial, looking at early implantation of TIPS in patients with cirrhosis and ascites. This is a prospective, randomized, open-label, multi-center interventional trial. Patients were randomized 1-to-1 to the intervention group with TIPS versus standard medical treatment. The primary endpoint is transplant-free survival, with secondary endpoints including time to ascites with need for paracentesis, as well as quality of life, which is assessed at both 6 and 12 months after randomization. The group's hypothesis is that early TIPS is, in these selected patients at the time of their first decompensating event may improve transplant-free survival compared to the standard medical therapy. And again, this is ongoing. So now we're going to talk about sort of the integrated approach and how to coordinate care in these patients and what's the role of the multidisciplinary team. As you all are very much aware, as in most of medicine, but especially within hepatology and in a patient population with cirrhosis and portal hypertension, integrated approach, multidisciplinary approach care is essential. And this can include all these areas that we know: hepatologists, gastroenterologists, other providers within hepatology, interventional radiologists, transplant surgery, all the way down to the radiologists, pathologists, case managers, social workers, et cetera. And why multidisciplinary care is so important is we need individualization of the patient's condition. We need a multi-pronged approach because there are so many different aspects to their treatment and their management that are needed. That also leads to the comprehensive care of the patient and all the relative complications that can be associated with cirrhosis and portal hypertension, ease of access, and then the dynamic approach that does change over time. The patient's condition may evolve over time, both clinically as well as psychosocial, excuse me. So just to wrap up some take-home points, clinically significant portal hypertension is identified as an HVPG measurement of greater than 10 millimeters of mercury, the presence of gastroesophageal varices, and the use of NITs, such as the rule of fives, as you heard. Progression of CSPH is associated with significantly increased risk of hepatic decompensation and death. That's a 10% risk of decompensation at 2 years and almost 31% at 5 years. Non-selective beta blockers, preferably carvedilol, with a dose of 12.5 milligrams per day, but in divided doses, as you heard, should be considered with for patients with compensated advanced chronic liver disease with CSPH to prevent decompensation. Management of esophageal varices includes vasoactive agents, antibiotics, early EGD for homeostasis or for homeostasis. There's growing data to support the idea of early or preemptive TIPS in patients with acute variceal hemorrhage within 72 hours, but ideally within or less than 24 hours from the initial endoscopy if possible, specifically in patients with Child-Pugh Class C or Child-Pugh Class B who have active bleeding on the initial endoscopy. Management of acute gastric varices involves vasoactive agents, antibiotics, and again, early EGD. Bleeding gastric varices, specifically the GOV2 and IGV1 or ectopic varices, it's recommended endoscopic glue therapy. TIPS or BRTO can be considered as first line, with TIPS and BRTO showing to be superior to glue. Management of ascites includes diagnostic paracentesis at initial diagnosis to rule out SBP and possibly hospitalization. Sodium restriction defined as less than 2,000 milligrams per day. diuretics at the lowest effective dose, and then a dietitian support specifically around the sodium restriction and protein. TIPS generally reserved for refractory ascites, but emerging data does suggest again that early TIPS may be associated with improved outcomes. Emerging role of earlier TIPS utilization is in both variceal and ascites management is showing potential benefit. The E-TIPS trial, which is the early implant, again, an ongoing early implantation of TIPS in patients with cirrhosis and ascites, with more information coming on that. And then the importance of the multidisciplinary team and management is critical for these complicated patients with cirrhosis, especially those with a high risk of decompensation. So with that, I'm going to turn it over to Dr. Wong, who will open it up for Q&A. There is a Q&A section in the chat that you are welcome to add your questions to. And at this time, I'll turn it over back to Dr. Wong.
Perfect. Thank you, Patrick. For the audience that are listening live, yes, please submit questions and we can attempt to answer. But maybe I want to start the conversation about the role of early TIPS with variceal bleeding. As Patrick, showed in some of the studies I showed, I mean, these are things that have been studied for 10 plus years, showing early TIPS as a benefit. But in real world practice, I'm curious what you guys have seen or what your centers have done. At least in our case, if someone presents with bleeding and we ban them and they stop bleeding, we're like, great, we call that a success, and we don't, necessarily always remember to think about early TIPS. So I'm curious to hear from each of you. What's your approach? Is this something you've seen at your center? Is it growing in kind of popularity to do this?
Yeah, I'm happy to get started on this one. I think that's a great question because I believe there are important differences in approach and what that threshold is for early TIPS. Within our liver community, I think the awareness is actually relatively high because I think this data are quite compelling and the guidelines are actually quite clear as to the target population for whom early TIPS should be considered. But we're mindful that the decision is not always solely in the hands of us as GI liver clinicians, but in context of the hospital service, often in the step-down unit or the ICU. In some cases, the primary management, the first consult goes to the GI endoscopy team. And you're right, if someone has achieved hemostasis and they're clinically doing well, hemodynamically stable, stabilizing, being transitioned to a medical floor, they have stable hemoglobin, no recurrent hemorrhage, on a antibiotics, beta blocker, the whole bit. There's real reasonable questions being asked by the primary teams when we say, we really should be thinking about early TIPS for these reasons. Now, I think that when there's a rebleeding, there's no question mark that those patients benefit from TIPS, and there's no argument there. But for those where there was some question mark about the source of bleeding, in other words, there was an active hemorrhage in a child PUB, I think that, as you know, it's often a soft call in terms of the etiology, in terms of varices, particularly in context of someone who also happens to have portal gastropathy. And then for those who have no evidence of active bleeding but their child PUC, we actually get some pushback not only by the primary team, but often in cases by the interventional rheologist whom we consult. And so I think you hit it on the head. I think in real terms of real world practice, that the utilization of early TIPS is probably far lower than perhaps what is formally supported by data or the recommendations. And so my own thought is that it requires we as GI liver clinicians to have those conversations with the teams and IR colleagues to demonstrate why we feel the benefit is high. And because we've had many cases now in our own center where patients who qualified eventually had further rebleeding with other untoward complications of their decompensation, I think we've had much more productive conversations about early intervention. But as I think we highlighted earlier by both Patrick and Robert, it's all about patient selection because some of these patients also happen to have really high MELD scores. They have heart disease, lung disease, et cetera. And so you're trying to really kind of cherry pick the patients for whom we think the benefit clearly outweighs the risk.
Yeah, and I would agree with you, Dr. Lim. And I think what your experience is very similar to what we experience at our center as well. And I think to me, one of the hesitations is always, you know, seen as tips as such is a essentially a permanent thing, is really in trying to make the decision, is that the right approach long term for that patient. You may not always know whether that patient may ultimately be a transplant candidate in the future, and with the risk potentially of hepatic encephalopathy, even though that some of the data shows that there really wasn't an increased development of post TIPS encephalopathy, especially in these early TIPS patients. It's trying to really, in the acute setting, decide whether or not this particular patient would benefit from early tips versus not. And it sometimes is hard, I think, to um, push colleagues or even interventional radiology, as you said, if the bleeding is gotten under very easy control with banding and with beta blockers. There's no evidence of a recurrent bleed, and so that might sway us one way or the other, even though the data may shows that early tips may be beneficial. I agree with you that a recurrent bleed is certainly a situation that I think where tips is much higher on most people's radar, because again, it is a recurrent event.
Yeah, well, I want to thank Patrick and Joe for joining me on this really wonderful, comprehensive presentation. I want to thank all of the audience that joined us this evening. It's a lot of information, I know, but don't fear. Go to the Chronic Liver Disease website. This webcast is available for your review if you want to go back and get a refresher, remind yourself of some of the things that we discussed. One final reminder, you will be getting an email for a post-test, so please complete that, give us feedback, and also collect your CME credits. With that, I want to thank all of you for joining us tonight, and I will wrap it up and close the session. Thank you, everyone.